I'm Steve Hines. I'm director of the College of Veterinary Medicine Teaching Academy. And as you guys probably know by now, I'm very excited about today's speakers. Been inundating you with emails, but I'm very proud to introduce our speakers today. This first session is going to be conducted by Dr. Nikki Woods, and she'll be helped later, and we'll have hear more later from Dr. Maria Myopoulos. And these guys are both associate directors and scientists at the Wilson Center, which is the University of Toronto School of Medicine. And their background is in cognitive psychology, but their areas of interest for Nikki has largely been integration, so how basic science and biomedical knowledge fits into clinical reasoning and clinical skills. And Maria's expertise is in adaptive expertise, which is what we like for our physicians, but also our students as veterinarians to have when they get done, the ability to adapt when they see new things they haven't seen before. And so we're going to start off with our keynote today at noon. There's another session today between 3 and 5, so I hope some of you will come. That'll be more of an active session. And so I'll turn it over to Nikki. We're really happy to have you. Join me in welcoming Nikki here today.
Thank you very much for the invitation. Maria and I are also excited to be here, just as excited as you are to have us here. We appreciate the opportunity to come and share with you a little bit of the work that we've been doing within our own labs and the work that we've been doing within the medical program at U of T. So as you've already heard, I'm a cognitive psychologist by training. And so the title of my session today is How We Know What Isn't So. And I have stolen that title. It is not mine. It is very clever. It comes from a book by a cognitive psychologist named Paul Gilovich. And the book is all about, it's actually an excellent book. It's quite old now, but it really is very good. And it's all about the fallibility of everyday human reasoning. And so the book talks about how it is that human beings like us can walk around the world, make very important decisions, be very, very assured of the value of those decisions, of the correctness of those decisions, that we can believe things very wholeheartedly, emphatically, and be absolutely wrong about them. And so what I'm hoping to do today is talk to you a little bit about some of the things that I think educators can believe wholeheartely, be very committed to, make very important decisions about, and be very, very wrong at the same time. And so we're going to use, some of my interest is on the integration of basic and clinical sciences. And so we're going to use that as a case study for thinking about some of the things we all believe to be true in education and questioning whether or not we're actually right about them. So what are some of the things that we know when it comes to basic science and clinical education? One of the things I think it's fair to say we all feel like we know is that when it comes to education in the health professions, when it comes to education in medicine, basic science is essential. We want our physicians, our nurses, our dentists, our vets to have an understanding of basic science. It's an important part of clinical practice. And I say this is something that we know because we've relied on this principle for over 100 years across the health professions and education. We've insisted that students have basic science prerequisites before they enter our programs. We hire basic scientists to be part of our schools on the assumption that there's an important part of what they do that has to be a part of our programs. So we do know that basic science is essential. We also know that science is continuously advancing. So anytime there are these large consortiums talking about the future of health professions education, the future of medicine, a lot of the things we talk about is this rapid advancement in science, that science is changing every day, and we have to make sure that our students are able to keep up with these rapid advancements. It's actually one of the things that keeps our basic science departments running, is this idea that science is always moving and changing, and we have to, as universities, be at the cusp of that scientific change. But there's also some things we don't quite know. We don't know how much basic science students really need to have. So do they have to have an entire undergraduate degree in biochemistry before they enter our programs? I don't know. Do they have to have 6 weeks of biochemistry at the beginning of the program? Frankly, the funny thing with health professions programs is the how much question always turns into the number of weeks of anything, right? So how many weeks of this? How many hours of this? It's a very strange way to quantify knowledge, but it's something that we do very frequently in the health professions, right? And we don't really know the answer. We don't have a clear-cut answer on how much is enough basic science. We also don't really know when. When is the appropriate time for students to be exposed to basic science education? When do they need this to become an important part of their training? Sometimes the answer is kind of given to us. So for many years, the when meant in the first 2 years of training. So across the health professions, almost all of them really have the basic science located in the early part of the training program, whether it's nursing, dentistry, whatever. It's always at the very early stages. So in medicine, we had a 2+2 curriculum for many, many years, where students did 2 years of basic science, followed by 2 years of clinical sciences. So they go ahead and they do their apprenticeships, they go on the wards, and that's a pretty standard structure. And that may have worked for us for many years, but as curricula start to evolve, the when question becomes really important. Because what happens in newer schools is that students are getting more and more clinical exposure earlier in training. They're asking to get clinical exposure on the first day of training. So if we move clinical experiences to earlier on in the program, when are we going to do our basic science education? So we see a lot of training programs that are really built on this idea of bringing in early clinical exposure. I see very few schools that try to put basic sciences into the 3rd and 4th year to make up for that early loss. So when is the appropriate time for basic science? The biggest thing we don't know is why. Why are we doing this anyway? So yes, we all seem to think basic science is essential. Yes, science is rapidly advancing, but why? Why do students need to have an understanding of basic science? What is that knowledge really doing for us? And what's fascinating to me is that this why question continues to be unanswered, despite the fact that we've been asking the why question for over 100 years. So the idea about why do health professionals need to have a background in basic science, it's not a new question, right? So this is something we've been asking for a very long time. My colleague, Cynthia Whitehead, who's actually the director of our center in Toronto, did a lot of work a few years ago to put together a really nice paper where she looked at the historical evolution of the idea of science as being fundamental to practice in the health professions. And what she finds is that a recurring theme again and again in over 100 years of literature is this idea that being a scientist, that having scientific foundations is an essential part of being a good doctor. And we've been saying that since the time of Flexner. However, at the same time, over the course of the 100 years, we've had a lot of people who've been questioning this. So I have here a quote from J.C. Meekins, who was the president of McGill at the time, in 1937. And he says, the majority of students naturally think of the individual patient and his illness as the important goal. Therefore, they're inclined to find the meticulous study of anatomy, physiology, and biochemistry rather boring. They think their study a waste of time. To what extent has the teacher of medicine or surgery or gynecology and obstetrics employed the knowledge and techniques of these subjects in the teaching of his own? I chose that quote because it's from 1937, which is only a few years after the introduction of basic sciences as a core element in all medical schools across North America. We can trace the inclusion, we're going to talk a little bit about this tomorrow, but we can trace this back to the Flexner Report, which came out in 1910. And at the start of that report, or at the time of that report, medical schools across North America changed substantially to include more basic science. And here we have, just a few years later, someone saying, why are we doing this? What's the point? So this is something that we have to agree, at least for the moment, we don't really know. After 100 years, we don't know why basic sciences are part of our health professions programs. Despite the fact that we don't really know, people have very, very strong opinions and beliefs about what should happen in our programs when it comes to basic science content. And so a few years back, a group out of the Netherlands actually went out and surveyed basic science teachers and clinical teachers who have duties in medical schools, and asked them about the required content needed for students at the time of graduation. And what they found is that basic science teachers and clinical teachers could generally agree on the amount and depth of clinical content that was needed for medical students at the time of graduation. So if we're talking about clinical knowledge, everybody agrees. They agree on what students need to know, and they agree how much of it they need to know. When it comes to basic science knowledge, and it doesn't matter if we're talking about organ level, cellular level, molecular level, basic science teachers across the board judged that medical students need to have much deeper knowledge. Okay, so they're like, they need to understand these concepts, they need to learn at the molecular level. In comparison, our clinical teachers think they don't need nearly that much of that basic science. Okay? So not only do they not need the same amount of depth, they argue that there's too much basic science in the curriculum. And this is an interesting problem. So here we have these two groups that are responsible for training. They have to work together to put together a program, and they have a fundamental disagreement, deeply held disagreement, about what's going to be needed. You might think that the trick to this, the solution to this, is simply to make sure that everyone understands what medicine really is. Expose people to what medical practice is. Expose people to what it really means to train as a future nurse, as a future dentist. And what we have found is that, or not I have found this, but others have found, is that when basic scientists get more exposure to med schools, they see even more relevance of their basic science content. So exposing them to the realities of clinical practice makes people even more firmly believe that basic science is necessary. So how are we going to actually convince the sides of that it is possible that there's something that they just don't know? And I would argue that for both groups, for both camps, the basic scientists and the clinical scientists or clinical teachers, both groups know something that just isn't so. They're actually both wrong in this instance. And they're wrong because neither group is making their decision or holding their assertions based on evidence. What they're doing is thinking about their own practice. To answer this question, we can't just ask people to think about their own practice and guess about what's important. What we need to do is actually study it. This is a scientific question. This is a research question. What's the value of basic science? Why do students need to know it? And so I started off my research a number of years ago now, actually trying to answer this question. What is the value of basic science in clinical diagnosis? And so we set this up as an empirical investigation based on theories and work in cognitive psychology. So what we did was we randomly assigned students who were enrolled in the University of Toronto medical program. So these were students who were in their first or second year of the program. And we randomly assigned them to one of two learning conditions. The students are going to be asked to learn 4 different categories of neurological disease. They're doing this outside of class time, and it's not part of the course. They're just doing this because, well, we paid them, but that's not the point. They're doing this to participate. So the students who are assigned to the basic science condition are going to learn the 4 categories of neurological disease, and we're going to teach them the signs and symptoms of each category, as well as the basic science mechanisms. We're going to use the basic science to explain why each sign and symptom occurs. The students who are assigned to our feature list condition are going to learn the same 4 neurological categories, but instead of the basic science, they're going to learn some epidemiology and some important facts about the 4 conditions. We present this to the students on customized computer programs, and they are listening to the most boring didactic lecture you could ever imagine. Okay? So this is not about what the students are going to have fun. They're not about whether they're going to like it. I guarantee they don't like it because no one likes it. They're boring. So this is not the point. What we're trying to understand is the value of the knowledge. Okay? So this is not about teaching strategy. It's about the knowledge. So we assign them to actually go through these customized computer programs. They're looking at slides and listening to audio recordings. And they're allowed to spend as much time as they'd like studying the material back and forth. Most students spend about 20 minutes going through the material. Once that's done, they move on to the testing phase. So in the testing phase, they're going to take a series of quizzes and tests. The first one is we call our supporting knowledge quiz. This is included just to make sure that students were paying attention. Again, we make you sit through a boring lecture. I need to know if you were actually listening or if you fell asleep. That's the sole purpose of that supporting quiz. Then they complete a recall quiz. This is a standard recall memory test taken from cognitive psychology where we present students with the name of the disease and they have to recognize or identify the symptoms that belong in each category. Finally, they complete a diagnostic test. So this is where we actually give them 15 patient cases. They have to review the patient case and tell us the most appropriate diagnosis for that patient. So we're not requiring that they explicitly use the basic science. We're requiring that they actually diagnose a patient. That's the point of medical behavior. That's the point of medical practice. They actually have to diagnose a patient. Then they go away for a week. Because this is outside of class time, I have no reason to believe that they would study or encounter the material. There's no reason. They wouldn't study. They barely wanted to learn it for the 20 minutes. Don't worry, they didn't study in that a week. They go away for a week, and then they come back, and they complete a brand new diagnostic test. They do 15 cases that they've never seen before, and then they also do some additional memory testing. The data that I'm going to show you comes from the diagnostic test only. We'll return to some of the other quizzes, but I'm just going to show you their performance on those clinical vignettes. And what you can see here is that on immediate testing, so that's right after the instruction phase, there's no difference between the two groups. Both groups perform the same. This is where our clinical colleagues in our earlier fight were right. You don't need the basic science in order to do this key medical task, diagnosis. Can you learn to diagnose without knowing anything about the basic science? Yes, you can. But after 1 week, as you see on our delayed performance, the students who had the basic science understanding outperform the students who didn't. That's where our basic science becomes useful. So it's not that you need it in order to learn to diagnose. You need it in order to retain that knowledge over time. So we know from this study and others like it, so I only show you that one, but you can trust me, we've done this study many, many times in many different contexts, in a lot of different ways. It's a very robust finding. So we know that the integration of basic science leads to retention of diagnostic performance over time. We're very confident in that fact. So in that sense, our basic science teachers, they were right a little bit. But they're also wrong. And they're wrong because what we know from all of these studies is that the amount of basic science needed is minimal. So they don't need to have an in-depth understanding of biochemistry, anatomy, physiology. It doesn't have to be in-depth, but it's got to be there. And the amount that's there is critical. So if that's the case, I could actually just stop there and say, done and done. I've solved everything, no need to fight, right? I know you've been fighting for 100 years, but I just ran this study with 20 people. We've solved the problem, right? And so the question is, how did we get into this fight to begin with, right? Why wasn't it obvious? Why would we actually have to have this debate for 100 years, only to have Nikki show up 100 years later and run this little study? How did we begin to have these incorrect notions to begin with? That's really the interesting question, is what causes us to make these mistakes as educators? What causes us to form these beliefs and hold on to them so dearly for 100 years? What's that? And I think that the key thing that we have to acknowledge, and this is going to be kind of the theme for the next couple of days and across the whole symposium, is that becoming an expert in any domain fundamentally changes your perception of the world, and certainly your perception of the domain. And across the health professions, the people responsible for curriculum are experts. That's why you're here. That's why you're a teacher. That's why you're the course director. That's why you're the dean. It's because you're an expert in the area. And the challenge with that is that in order to do education correctly, you don't need to see the world like an expert. You need to see it the way a novice does. And that is very, very difficult to do when you're really good at something. You'd have to somehow erase everything you know and act as though you don't know anything. And that's really, really tough. Well, for some people it's easier than others, but for most people, it's very, very difficult. Okay? So because I'm a psychologist, we have to do at least one psych demonstration because that's what we do. So we're gonna do a really quick psych demo just to really illustrate this point. So who's heard of the Stroop effect? Be honest, not you, Maria. If anyone other than Maria has heard of the Stroop effect, you cannot play, okay? We're going to do a demo. You don't play. Don't say anything. Just sit quietly. Don't say anything. And don't tell your neighbor anything about the Stroop effect, okay? What's going to happen is, I hope this works because of the color. It might be better to look at these screens because the color is a bit off in this one. What's going to happen is a column of shapes is going to show up on the screen. Your job is for each shape, go down the column, and ignore the shape and identify only the color of the object. Okay, so you see a shape, just say the color. Two things, you have to go quickly. If you think about this too hard, it doesn't work and it's just no fun. So you have to do quickly, and you have to do it out loud. Okay, that's the other rule. So everyone's gonna go as fast as they can, and everyone's gonna do it out loud. Okay, so ignore the shape, identify the color, Go quickly, say it out loud. Is everybody ready? All right, let's do this. Go. Excellent work. Okay, that was good. Everyone did a good job. Scale of 1 to 5, 1 being really easy, 5 being really, really difficult. Where would you rate that task? 1. Okay, everybody, that was a 1. Anyone? that should be a 1. Maybe a 1.5 if you're at the back or something like that. Okay, so we're going to do it again. We're going to have another trial. Instructions are the same. Okay, so column, ignore the shape, identify the color, going in a row as quickly as you can, and out loud. All right, ready? Go. Oh my goodness, the color naming in this group, not so good. Okay, scale of 1 to 5, what do we think? 2, 4, there we go. Okay, so 3, most people would say it's about a 3, 4. Either way, it's much more difficult, correct? Everyone can agree, the difficulty's hard. Why? Why is it tougher the second time around? So we've changed it to words, and what happens when you hit that first one, you see the word, and you start to say red, right? and you do that every single time. So why is this happening? This is happening because the one thing I knew, without talking to Steve, without doing anything, I knew everyone in here would be able to read, okay? You are all expert readers. Okay? That's one thing I know for sure. Everyone here is an expert at reading. Whether you read a lot or whether you like to read is not the point. What I know is that you're an expert reader. When you are an expert at reading, you cannot not read a word. Okay? If a word is in front of you, you're just going to read it. It's automatic. It's effortless. You can't help it. It's what you do. When we do this task with young children, guess what they're really good at? Color naming. Okay? So I have very young, when you have little kids, when they're 2 and 3, they name colors all the time. As an adult, you don't wander around the world pointing at objects and naming colors. But children actually do. Anytime you're with a little kid, you feel yourself doing it too. You start saying, what color is that? And what color is that? And we all so they're really great at color naming. They don't have any problem with this task. Why? They can't read and they're good color namers. Okay? When you are an expert at something, expert perception, it's automatic, and it is incredibly difficult to suppress your expert perception. How is this relevant to the basic science question? Well, it's relevant because I would argue that teachers who are experts in their field automatically bring the lens of their expertise to their education problems and to their practice problems. So that means that the basic science expert who gets to see the medical classroom, who gets to see the medical ward, brings their lens, they bring their expertise to that view, and they can see how relevant the basic science is. So just showing them the realities of medicine isn't going to help because they're going to be even more convinced, well, yeah, I can see the biochemistry all over the place. Right? They can always see the relevance because they're experts at it. So the basic science expert always brings their scientific lens to a medical problem. The expert physician is also making a mistake, though, because expert physicians will often report that they don't use their basic science knowledge to solve clinical problems. They'll say, I have no idea why I had to learn the Krebs cycle. I never used any of this information in my daily practice. I don't use basic science, blah, blah, blah. But the truth is, they have no idea how they solve a problem. Okay? We know from other work that biomedical knowledge over time, as you develop expertise, can become encapsulated underneath clinical knowledge. And so an expert might be completely unaware of the influence of basic science knowledge on their ability to solve a clinical problem. So we wanted to actually test this idea as well. Can basic science start to influence your perception? Can your understanding of mechanism, understanding of science, influence your perception of a diagnostic task without you being aware of it? And it's a tough thing to study because, again, you need people who are not really experts because we can't rely on them to suppress their expertise. So what do? We make up diseases that no one is an expert in except for me because I made them up. So what we did was we created 4 artificial diseases. We took some regular endocrine disorders, hypothyroidism, hyperthyroidism, mix up all the symptoms and create 4 brand new categories for which there are 2 experts in the world, myself and my colleague Sam. The diseases are Zemus, Comaria, chronic thymus, and Angler's disease, which is awful. You do not want it. What we do is we brought students into the lab, and we're going to teach them these artificial diseases. So these are psychology students in this experiment. We teach them artificial diseases. In our causal learning condition, the students learn the 4 disorders, the signs and symptoms associated with those disorders, and they learn a causal mechanism that explains why those signs and symptoms occur. Now, we're calling it causal in this case. We're not really calling it basic science because they're made-up diseases in the whole 9 yards, but you understand my point here. The students in the other group, same 4 diseases, but they just learned the signs and symptoms without the causal story. Okay, so now we can test the effect of this causal understanding on your unconscious behavior, because we know we don't have to worry about your prior expertise. Any expert effects we see now have to be due to the causal learning that we provided in the instruction phase. The students do studying, they do some comprehension tests, they do a recall quiz, then they do a diagnostic test where we give them 8 fairly long cases to work their way through. They go away for a week, and when they return, we do something that's really fun from cognitive psychology. It's based on a lexical decision test, and it's a recognition memory test. I'm going to walk you through how that works. Essentially, what we're trying to do is test the influence of a previous experience on your unconscious processing of current information. So the students brought into the lab, they're looking at a computer screen. There's a fixation cross at the center of the screen. The fixation cross remains on the screen for 30 seconds, or actually, no, it's 25 seconds. I know you guys don't care, but for psychologists, it matters. So it stays up for a few seconds, the fixation cross disappears, and a word takes its place. The student has to read the word and make a very quick judgment. Press 1 if you remember this word from one of the 8 cases that you saw last week. Press 2 if you do not remember this word from the cases, any of the cases that you saw last week. They have to make that judgment quickly, because again, we're trying to get at unconscious processing. Make that judgment quickly, and as soon as they make the judgment, the word disappears and a cross reappears, and the trials continue. Okay? So psychologists use this to test influence on memory without requiring explicit recall. What we're using it for is we're going to manipulate the words to test their memory and the influence of the causal mechanisms without requiring them to explicitly tell us. So we present different types of words. We can present a feature. So a feature is a symptom or a sign or a symptom that was in one of the cases. So it's one of our symptoms. It was definitely in one of the 8 cases. We can also present an encapsulation. Remember I explained to you that encapsulated knowledge usually refers to biomedical knowledge, causal stories that are encapsulated under clinical items. So it's essentially a word that represents the causal mechanism. The key thing is it never actually occurred in any of the cases. So if a student says yes to this word, I know their understanding of the mechanism is influencing their perception, not their explicit use of that knowledge. If they were using explicit memory, they would say no because it never occurred. It was never mentioned. Okay? So this is a way that we're going to pick up on unconscious influence. So we show encapsulations. We can also show inference items. Again, an inference item is one of these words that makes sense if you understand the causal story, but it was never actually presented. So the question is, if you say yes to this, then I know the basic science is influencing your perception, but it can't be explicit, because if it's explicit, you would have said no. Okay? We also present them with novel, same thing. The novel items are related, but were never shown. And then we have foils. Foils never showed, were not related. It says cough, you should not say yes, because it has nothing to do with anything. Okay? So what we found, there we go, is the data. And so what you see is there's no difference between the 2 groups. The feature list is in blue, causal story is in white. There's no difference on the features, which is great. That means everybody remembers and learns the signs and symptoms in the 4 disorders. Where we do see people actually unconsciously recognizing the causal story is for the group in our causal learning condition. So those students are actually saying yes at a significantly higher rate to these words that never actually occurred. That's where we're seeing the influence of their causal understanding. This pattern, and again, and lucky for us, hardly anyone says yes to the foils, so that's a good manipulation check. This pattern of results is very similar to what we see in similar tasks with expert physicians compared to novices, where expert physicians are more likely to say yes to encapsulated items, showing the influence of their biomedical understanding, and these are the same people who will argue they don't use their basic science to solve everyday problems. So we know that instruction that integrates basic and clinical sciences can actually lead to almost this instant expert performance on an unconscious memory task. So we can make the students look almost like experts right away. The key thing here, though, is that this influence of basic science can be subtle and it can be unconscious. So it's not that we don't know why basic science is important. It's that sometimes we don't see why basic science is important. And that's an important distinction. We might just be missing it. So the question is, what is it that we're not seeing? Okay? So if we're missing something, what is it that we're missing? What is the basic science doing for us anyway? What's the actual purpose? And so this is some work that was done by one of my students, Christina Lisk, and Christina wanted to understand how basic science is actually being used by students in these learning scenarios. So again, she randomly assigned students to 2 different groups. One group, our basic science condition, is learning anatomy. And this one, they're actually learning to diagnose 4 different disorders of the hand, musculoskeletal disorders. So one group learns anatomy, the other group learns epidemiology. Protocol is basically the same. They do study phase, recall quiz. They do a diagnostic accuracy test. So they get a series of cases, and they have to select the most appropriate diagnosis. They go away for a week. They come back, they do some more diagnostic cases, and then we ask them to do a diagnostic justification task. So for this one, what we do is we don't ask them to diagnose the case. We present the case, we tell them the correct diagnosis, so this is the diagnosis for the patient, and now we say the patient's asked you to justify your diagnosis. In the box below, provide your patient with a detailed explanation of why this is the diagnosis. Be very specific. Use up all the space you want. Okay? And then what we did is we had a bunch of experts actually score these explanations. So we're looking to see, do the basic science students, the students in this basic science condition, actually use that information in their justification? How is it actually influencing their decision? And so we had a bunch of experts score the cases, actually looking through what are the students doing? Are they identifying the correct signs and symptoms? Are they actually explaining and giving an explicit rationale? So you can see here that what we actually did was we scored whether or not there was a rationale rooted in basic science that was given for the diagnosis or not, as well as what features were they identifying. Okay? And so here's the data on the diagnostic test. And what we found was very typical of these experiments. You should all be used to the pattern by now. What we find is that the basic science group outperforms our clinical science group. And this time, they actually outperform them on both immediate testing and delayed testing. And this is something that we see often in the lab when the diagnostic task is more challenging. So when you have a really challenging diagnostic task, you can see these effects right away, right after learning. So that was great. Now the question is, what did they do in that diagnostic justification phase? And what we found is when we looked at what they were actually writing, the students in our basic science condition made 2 big differences compared to the students in the clinical group. One of the things they did is that they tended to identify what we called key symptoms. So you can look at a symptom and identify, yes, this is the diagnosis because this symptom belongs to diagnosis X. The problem is that symptom might occur across all 4 conditions. So that's not a key symptom. What we want students to be picking up is the distinguishing symptom, the key symptom. And what we found was that our students in our basic science condition were much more likely to identify that key symptom. What they didn't do was really give any real rationale that was an explicit basic science. So they don't say anything about the basic science, but it's obviously influencing their choice. So what that tells us, and not just this study, but we've done a bunch of other studies like this, and it tells us that the students' understanding of basic science is not affecting their memory for the signs and symptoms, it's affecting how they're using that knowledge. It affects how they put it all together. It affects how they make sense of it. And we call this conceptual coherence. The idea, and we're going to talk about this tomorrow in the workshop more fully, but the basic idea is that the basic science knowledge helps you develop this more coherent understanding of the disease. So it's not your acquisition of the knowledge, it's your ability to use it to solve clinical problems, whether you're aware of it or not. The key thing for educators to keep in mind is that the way we assess students can actually make this conceptual coherence invisible. So in Christina's studies, if we didn't have that diagnostic justification test, we would have no idea how the students got this answer. And we would never know that they did this based on basic science knowledge. So the question for us as educators is to think about our assessments, and are we picking up on this form of knowledge when we assess our students? What else could we possibly be doing? So in this instance, I've given you an example already of how our assessments can be maybe hiding some of this basic science understanding. But I think there are other things that we do as educators that can actually disrupt the use of basic science knowledge and cause us to continuously think that basic science doesn't have value. And in this study, this is done with dentistry students. So this is Mariam Baghdadi did this work with dental students and dental hygiene students. And what she did is she wanted to actually look at how the effect of instructions and the effect of strategies that we teach students can actually impact their use of basic science. So again, we have two different groups of students randomly assigned outside of class time, no cheating allowed. One group learns basic science explanations. The other group learns an algorithm that was developed at U of T for teaching this is oral radiology. So they're actually learning how to diagnose patients and how to look at x-rays. And so we teach them an algorithm that helps them understand the picture in front of them. So, but there's no basic science in the algorithm. So they go through a study phase, a recall quiz. Then they enter the diagnostic test phase, which is this first colored row here. When they are presented with a case, now what we do is we randomly assign students, half of the students in both conditions, to one of two instructional strategies. So we manipulate the instructional strategy. One half of the students is told, when the x-ray comes up, I want you to first tell me what you think the diagnosis is. Just say what you think is the right answer. After that, I want you to go back and identify all of the correct features in the x-ray that would support that diagnosis. The other group is told, don't jump the gun, don't jump to the diagnosis. What I want you to do is just tell me what's going on, list all of the features, and then we'll get to the diagnosis. We chose these two instructional strategies because they represent things that clinical teachers often do when they have students in front of them. So they say, I want you to take a look at the patient, don't tell me the diagnosis. I want you to first take your time, go through it, tell me all the signs and symptoms, and then we'll look at the diagnosis. So that's what we did. They go away for a week, they return, they do a brand new set of cases with the same set of instructions. This time I'm going to break up the data. We're going to look at the diagnostic test, but I'm going to first show you just immediate testing because it just makes it cleaner to look at. And if we look at their immediate scores, the first thing you'll notice is that the two groups look the same. They look basically identical. What you'll also notice is that the group that's told to give the diagnosis first outperforms the group that's told to do the features first. And they do that regardless of whether they were in the basic science condition or the algorithm condition. So we've learned two things to this. Number one, the way we usually tell students to process a case might be inappropriate, but number two, that decision to change the instructional strategy completely obliterates any effect of basic science. Because we've done this study before without that instructional manipulation, and the basic science group outperforms the algorithm group every single time. And so what that tells us is that we can spend a lot of energy creating integrated instruction. We can spend all sorts of time in the first year making sure people understand basic science. But if later on we don't give them the right instruction at the time of diagnosis, we can completely obliterate all of that work. When we look at their delayed performance, we see the same thing. In fact, the effect gets bigger. So what that tells us is that clinical instruction, the things that we do to help our students and make the task easier, can sometimes unintentionally make underlying knowledge invisible. And so it's something that we have to be mindful of. These little things that we've embedded into our habits, sometimes into our formal curriculum, more often into our informal habits, can actually make it impossible to detect the value of conceptual coherence, the role of this invisible knowledge. And I don't fault teachers for taking that approach. When an instructor tells a student, don't jump the gun, you have to do this in an analytic way, they're using their own experience. They're saying, as an expert, this is what I think you should do. But the truth is, a novice sees and processes the world in a completely different way than an expert. So rather than making our choices based on what we think they should do, we should probably take an opportunity to look at the evidence. Is there evidence that this is the best teaching strategy? Is there evidence that this is an appropriate way for a novice to process a problem? If there's not, then maybe I shouldn't hold this belief to be absolutely certain. The subtle and fragile nature of basic science, admitting that it might be unconscious, admitting that it's easy to disrupt, doesn't mean that it's not valuable or that it's not useful. It just means it's tough. And I think it's really important to keep in mind that when we're designing our instruction and we're designing our assessments, we should be basing these decisions on our science rather than our own ideals. Because it's often the case that the things that we believe to be true, the things that we know are true, just aren't so. So we're hoping that we've started you off thinking about this today, and over the next few sessions, we're gonna keep coming back to this idea about what are the things that I fundamentally believe as a teacher, and might I be horribly, terribly wrong in those ideas. I'm going to stop there and take questions, but before I do that, I'm going to thank the people who helped with this work. So Mariam Baghdadi and Christina Lisk, I presented both of their work today. They worked with me doing their PhD, and they've done amazing work. I've just shown a couple of their studies. They have others that are awesome. Maria is right here, so thank you, Maria. As well as the work was funded by the Medical Council of Canada, the Higher Education Equality Council of Ontario. Doug Buller works with us at the Wilson Centre. He is our multimedia guy, and Doug makes all of the slides. So I will thank Doug right now and for the next couple of days. As you see beautiful slides, we do not make slides. Doug makes the slides. Thank you for Doug for the slides. And I'm going to leave my email address here. I'm always happy to take questions. I'm always happy to answer emails. We have copies of these papers. We can send them out if you're interested. So certainly, please reach out and let us know. But I will stop here and take any questions if people have them. Thank you. On the foils, it wasn't real, yeah. I know what happened when I moved the graphs over, my error bars disappeared, and I got frustrated, tried to put them back. But there was no difference on the foils. There was a difference on the inferences. I collapsed together the inferences novel because it was getting too long, but there was no difference on the foil. I know it looked like it did, but yeah. Hi.
Really interesting talk.
Oh, sorry, you have it.
You really show solid data as to how basic sciences actually helps students, and especially at the encapsulation phase. In your studies, did you look at answering question as to how much? So were there any studies done where maybe a group had a lot more basic science than they needed, then another group had maybe just what they needed,
yeah,
and see how much and how does that influence?
Yeah, so we have, it's a funny thing. We have that study designed, like we have the materials all ready to go. We just need a student to kind of take it on and run with it. But in the meantime, what I do have is we have two things. So the way we design these materials, we use very little basic science. So we use just enough. We call it our toddler rule. So we're trying to answer why questions, and we just want to answer 2 whys for each mechanism, for each symptom. That's it. But in previous iterations of this work, we did use really long explanations of basic science, and we could not get these effects. So we have tons of failed null result studies where we simply used too much basic science and we weren't getting the effect. The clinical group was outperforming the basic science group significantly. And so it just wasn't working. And so we tried again and again trying to play with it. And what ended up happening with those ones is that what we found was when there was too much basic science, the students were ignoring it. So they're really good at just not learning it. And that's a problem scientifically, because now what we're doing is we're comparing a group that learned something easily and a group that was struggling to find the relevance within all of this basic science. And that's not a fair comparison. So from that mismatch, that's where we get this idea that it really doesn't need that much basic science.
So, did you ever think of looking at education in Europe, where we have students who go directly from high school into medical school, as opposed to students here who go and get an undergraduate degree and then go to medical school?
Yeah, so I just saw a note here to repeat the question. So the question is if we've ever looked at students who don't have science prereqs, for example, who in Europe. So Europe, they let students into medical school without any sort of science background, and is there a difference? So a lot of the work that the group that I was talking about that did the lexical decision task, the group that looked at basic science versus clinical teachers, they're all European. So this is a very big, this work starts there. All encapsulation theory comes out of the Netherlands. It's a big topic for them, is whether or not you need the basic science. And what they tend to find is you don't need it beforehand. And I think it's funny because in North America, we've got this obsessive idea that they have to have it before they get here. The model in Europe is just be able to learn. We'll teach you the stuff you need to know when you arrive. We're not too fussed about whether or not you have the basic science or don't have the basic science. And so it doesn't seem to have as much value to have the prereqs as it does to have solid training once you arrive. At McMaster University, they've looked at, so at McMaster University in Hamilton, Ontario, they do allow students to come into the program who don't have basic science background. So they'll accept students who are from humanities, music, art, doesn't matter, they can apply. And they don't even require that they take the MCAT necessarily. Now they're requiring a small section of the MCAT. And what they've shown is that those students in a PBL curriculum struggle a little bit in the first year, but they eventually catch up. And there's no difference between those students and the students who had the natural science backgrounds. They do not perform any differently once you get to third year. And that makes sense. Obviously, you're going to struggle a little bit at the beginning if you're the only one who doesn't know the anatomy of the heart and everybody else does. But if you're a smart student and you're willing to work, you'll figure it out, and you'll get there.
Thank you very much. That was very interesting. And I'm getting ready to go teach a problem-solving class right after this. I'm going to go back. And I'm sure you're familiar with the problem-oriented medical record and problem-oriented approach, and which is what we very commonly do, is have our case with our diagnosis and the problems. And what I was planning to do is we look at the problems and the differentials for each of those problems, and then the common denominator differential for all of those problems is cardiovascular disease. Mm-hmm. So that must be the diagnosis. Yay. But you're suggesting that you should give the information, then ask for the diagnosis perhaps, and then have them justify those problems to meet the diagnosis.
Yeah, so this whole thing about which you do first is kind of a funny thing. So in this particular version of the study, they have a case in front of them, and they have to just say the diagnosis as quickly, not quickly, but say the diagnosis and then go back and justify it. So that finding in this version of the experiment was certainly the better approach. What we've seen in some other work, so other people have tried to manipulate this specifically and study exactly this question, which should you do first? And they tend to find that the group that wins out is like a combined approach. So the issue is, can students, they talk about it as analytic versus non-analytic. And historically, people have argued students shouldn't be encouraged to do non-analytic processing because they don't know enough. And so you need them to do analytic, which is the step by step by step. And what that work shows is that what you want students to do is a combination. So you want to first get them to think about the diagnosis, but don't jump the gun. So think about the diagnosis, generate the diagnosis, then go back and check with the analytic strategy. Now justify it. And so that's been studied in a few different places in a few different ways, and I think that's where they've kind of landed, is that a combined approach is best. But it's not typical. It's not what people usually do when they create the programs. And for a long time, this was an ongoing debate between a group at McMaster and a group at Calgary, and they kept kind of trading studies back and forth showing which one was better. But I think McMaster might have won.
Thank you.
I enjoyed your talk. Thank you. I just had a question. So this is about medical education for medical students. What about for residents, for instance, where they want to become experts in certain fields? Do you kind of change the approach to teaching?
You know what? I haven't done a lot of this work in residency, and we're starting to look at it now, but I still think that the same concepts hold true. So what's useful for basic science, the reason basic science knowledge becomes useful is because it helps you develop a deeper and richer understanding. It's an understanding of mechanism that helps you put things together and make sense of it. And certainly at the residency level, that's important. And I think that when we talk about basic science and clinical, it matters a lot because in residency, that's where you really very rarely see any discussion of basic science. Like people assume that that was already taken care of, and people delve really, really deeply into the clinical side and skip the basic science. And I actually think that's a mistake. I think it's a really important time to revisit this deeper understanding, this understanding of mechanism and how things really work. Residency is a great time to do that, but we often just don't. So we have some studies designed right now we're hoping to do in family medicine residency, but stay tuned. We'll send you the paper.
You guys are out of time. I hope you guys, some of you will come. We're going to talk next about how we do these things in our curriculum, now that we've got some underpinning and a conceptual framework. But I'd like you to help me thank our speaker today.